Hello students, welcome again back to the class. Let us see what is body size and how it can be assessed. It is a part of the anthropometric measurements. So, body size can be assessed from the measurements of the stature, which can be height or length, weight and head circumference using standardized procedures which are described in this chapter. When height cannot be measured, published equations based on knee height, lower leg length, arm span or demispan are used. To interpret the measurements, indices such as weight for age, body mass index for age, stature for age, weight for stature and body mass index, that is weight by height square, are constructed. To evaluate the body measurements or anthropometric indices, they can be compared with appropriate growth reference data using Z scores or percentiles. So, for international use, the WHO has prescribed child growth standard for children, that is for 0 to 5 years, and the WHO growth reference for school age children and adolescents between 5 to 19 years, which should be used. Statistically determined reference limits or cutoffs can also be applied to generate anthropometric indicators such as stunting, which is stature for age lesser than 2 Z score, wasting, weight for stature, which is lesser than -2 Z score, overweight, which is weight for stature more than +2 Z score, and thinness, overweight, obesity based on BMI for age, which is less than -2 to more than +2 and more than +3 Z scores respectively. Both stature for age at less than -2 Z score and weight for stature at -2 Z score are recommended by WHO because together they can distinguish between stunting and wasting. What is the difference between stunting and wasting is, stunting is if the malnutrition duration is for a longer period, the height of the child remains standard and it cannot grow beyond that, and wasting, it indicates short term malnutrition where there is reduction in the muscle mass. So, to assess the change in stature over time, however, use of stature for age difference rather than stature for age Z score is now preferred. To assess and compare the severity of malnutrition across countries, 5 prevalence thresholds for wasting, overweight and stunting can be used. Recognition of an elevated mortality risk for children suffering from multiple anthropometric deficits simultaneously has led to the development of composite index of anthropometric growth failure. This is used to characterize overall burden of under and over nutrition in children aged less than 5 years, so that they can be identified and prioritized for an intervention. Changes in the body weight over time are used in both clinical and public health settings. In clinical settings, lack of weight gain and weight loss are used to identify pediatric undernutrition, whereas weekly weight gain is used to monitor response of children with severe acute malnutrition to feeding programs. In public health, changes in body weight over time are often monitored because of their increased risk of mortality. New US guidelines for gestational weight gain are now available, which have been adopted by WHO for low income population until specific country cutoffs are available. Now, BMI is currently the indicator of choice for defining underweight, overweight and obesity in adults and children. However, the limitations of BMI alone has led to the use of both BMI as well as waist circumference, because the distribution of abdominal visceral fat has even greater cardiometabolic risk than excess of body fat per se. The BMI cutoffs used to classify adults underweight were BMI less than 18.5 kg per meter square, overweight BMI more than 25 kg per meter square, mortality and morbidity are more in such cases, and in case of obese the BMI is about 30 kg per meter square, and they have lot of health risks and sometimes mortality. In adults, WHO recommends the use of universal BMI cutoffs for overweight, where BMI is 25 kg per meter square and obesity 30 kg per meter square. 3 classes of obesity are also defined. This classification has been adopted by several countries including Canada and the United States, with the highest class indicative of severe obesity where the BMI is more than 40 kg per meter square. Now, the cutoffs to define grades of low BMI values indicative of underweight in adults are also recommended together with the classification to identify population with public health problem. Increasingly, low and middle income countries are impacted both by under and over nutrition and a condition termed as double burden of malnutrition. So, in children, no simple cutoff to define thinness, overweight or obesity can be used, because BMI has a characteristic curvilinear shape with age. Instead, countries have compiled their own ways of defining thinness, overweight and obesity in children. 3 classification schemes are described with cutoffs defined by BMI for age, Z-scores or percentiles based on international or national growth reference data. They include those set by the International Obesity Task Force, the new WHO classification based on their internal growth and growth reference, and the US classification based on 2000 CDC growth charts. Clearly, there is an urgent need for consensus on BMI cutoffs for thinness, overweight and obesity in childhood that are defined by adverse health risk. Only in this way can valid international comparisons across the countries on the prevalence of thinness, overweight and obesity in childhood can be made. Now, anthropometric assessment for body size. The most widely used anthropometric measurements of body size are those of stature, height or length and body weight. These measurements can be made quickly and easily with care and training accurately. Head circumference measurements are often taken in association with the stature. Indices such as head circumference for age, weight for stature and stature for age, and the ratio of weight to stature are derived from these measurements. Of these, stature for age and weight for stature have been recommended by WHO for use in low income countries. In combination, they can distinguish between stunting and wasting. There is also recognition that individual children may be simultaneously wasted and stunted, which has prompted interest in identifying the combination of the anthropometric deficits with the greatest risk of mortality. In epidemiological studies, body mass index, that is weight by height square as kg per meter square, is used to define thinness, overweight and obesity. And increasingly BMI is accompanied by waist circumference to provide an assessment of abdominal fat in children, adolescents and adults. In hospital settings, anthropometric indices of body size are used primarily to identify under or overnutrition and obesity and to monitor changes after nutrition intervention. Measurements of body size include head circumference, which is an important measurement because it is closely related to the brain size. It is often used with other measurements to detect the pathological conditions with either an unusually large or small head. Then recumbent length is measured for infants and children below 2 years. Height is measured in older children and adults. Interpretation of length and weight at birth and during later infancy requires a valid and precise estimation of gestational age. Making such an estimate is often difficult in many low income countries. To assess growth over short time periods, lower leg length in infants and children can be measured. In adults, knee height measurements are used to estimate height in those persons with severe spinal curvature and in those who are unable to stand. Alternately, arm span or demi arm span can be measured when actual height cannot be performed. Coming to the knee height in children aged over 3 years, the measurement of knee height in children is termed as kneemometry. This measurement is taken from the distance between the heel and the knee of the right leg, that is the lower length leg, when the child is sitting. At least 3 and preferably 6 measurements are needed for an accurate determination of the lower leg length in a child. A training period of several weeks is required prior to routine measuring of lower leg length in children below about 3 years. The main application of kneemometry is for physically disabled children and in certain pediatric units specializing in growth disorders. Kneemometry can also be used to assess the effect of therapeutic interventions, for example, steroid therapy, etc., on short term growth. By measuring knee height, growth increments in children are said to be detected more readily and over a shorter time frame than conventional height measurements. Moreover, knee height measurements can be made with greater precision. Several factors other than growth influence the measurement of lower leg length, hence must be controlled. Now, lower leg length in infants and children aged less than 3 years. The lower leg length is also used to measure short term changes in linear growth over 1 to 8 weeks during infancy and early childhood. For preterm infants and normal infants and toddlers less than 3 years, a hand held electronic kneemometer, a mini kneemometer or an inexpensive vernier or electronic caliper can be used. Reports for the TEM for these 3 instruments vary across studies, in part depending upon whether the readings are recorded blinded or not and the number of consecutive readings taken. In general, the inexpensive electronic caliper has a lower TEM than handled mini kneemometer and could be used when assessing lower leg length in preterm infants over a short time period. Arm span and demi span. Arm span, like knee height, is also highly correlated with stature and hence can be used as an alternative measurement when actual height cannot be used, such as in elderly persons, when degenerative and osteoporotic changes give rise to spine curvature. Arm span is also often used as an alternative to height for calculation of body mass index in older adults and as a reliable surrogate for both recumbent length and height in healthy children when these measurements are unobtainable or unreliable. Instead, of arm span. Demi span is sometimes used to assess body mass index in older adults when an actual height measurement is not possible. Demi span is a distance between midpoint of sternal notch or jugular notch at the larger visible dip in the neck in humans between the clavicles and the fingertips with the right arm outstretched laterally. This measurement is performed using retractable metal tape taken into the nearest millimeter. Weight in infants and young children can be measured using a suspended scale and a weighing sling. For a greater precision within 10 grams, a pediatric scale. For older children and adults, portable electronic digital scales with a tiring capacity are recommended. Elbow breadth is used as a measure for frame size, which is relatively independent of adiposity and age. It should be measured with a flat blade sliding calipers. WHO adopted these same cutoffs to define 3 grades of BMI, referred to as thinness in WHO and as underweight in WHO rather than FAO definition of chronic energy deficiency. In WHO, grade 1 is 70 to 18.4 kg meter square, termed as mild underweight. Grade 2 is 16 to 16.9 kg meter square, which is termed as moderate underweight, and grade 3 is less than 16 kg, which is severe underweight. And WHO also devised a classification system to identify populations with public health problem based on low BMI. The body mass index in adults, WHO International Obesity Task Force defined obesity as a condition in which abnormal or excessive fat accumulation may impair health, according to WHO 2000. They have recommended the use of graded classification both for overweight and obesity to compare weight status within and between populations, identify individuals and groups who are at increased risk of morbidity and mortality, identify priorities for intervention at both individual and community levels, allow interventions to be evaluated approximately. So, if you see the simple classification of adult chronic energy deficiency using BMI, the chronic energy deficiency grade and BMI in kg per meter square. For a normal individual, the BMI should be above 18.5 kg per meter square, and grade 1 17 to 18.4, grade 2 16 to 16.9 and grade 3 less than 16. But proposed classification of weight by BMI for adults for Asians has been developed again by WHO, and here you say underweight as less than 18.5 kg per meter square, which is low risk of morbidities, but risk of other clinical problems is increased. Normal weight is between 18.5 to 22.9 and overweight 23 or more than 23 kg per meter square. At risk 23 to 24.9, class 1 obesity 25 to 29.9, which has moderate risk, and class 2 obesity more than 30, which has severe risk of morbidities. And indices for weight relative to height, the power P in Benz index is calculated to minimize the direct relationship with height. So, here we have the weight by height ratio and the formula is weight by height. So, body mass index is weight by height square, ponderal index is height by weight, and Benz index is weight by height P. So, weight to height ratio indicate body weight in relation to height and are particularly useful for providing a measure of overweight and obesity in adult population. Hence, these ratios are sometimes referred to as obesity indices. At present time, the ratio most used in this way is the body mass index, also termed as Quetelet's index, calculated as weight in kg by height square in meters. The body mass index is used in preference to other weight by height indices, including weight by height ratio, ponderal index, Baines index, and BMI is now widely used to classify overweight and obesity in adults. Then the body mass index is relatively unbiased by height and correlates reasonably well with other anthropometric measurements for adiposity in adults, such as waist circumference and abdominal visceral fat. Body mass index is employed in large scale nutrition surveys and epidemiological studies as a measure of overweight and obesity. Measurements of weight and height are easy, quick and relatively non-invasive, more precise than skin fold thickness, and nevertheless, BMI does not quantify total body adiposity or distinguish between weight associated with muscle and weight associated with body fat. Hence, in some circumstances, an elevated BMI may result from excessive adiposity, muscularity or edema, and this is an inaccurate measurement for adiposity at individual level. Certain population groups may also be misclassified as overweight or obese based on BMI because of the differences in the body proportions and the relationship between BMI and body fat content. In addition, BMI conveys no information about the actual distribution of body fat, anomalies in the distribution of abdominal visceral fat, and in particular ectopic fat, that is the fat deposits in the liver, heart, muscle, pancreas and kidneys, which are now recognized to be even greater cardiometabolic risk than excess body fat. So, consequently, BMI alone can misrepresent the burden of abdominal visceral fat in a subgroup of individuals who are at highest cardiometabolic risk. Therefore, a BMI within the range does not necessarily prelude an increased cardiometabolic risk. In a community dwelling adult men in Korea, for example, the assessment of cardiometabolic risk based on high blood pressure, hyperglycemia and dyslipidemia was highest among those with BMI lesser than 25 kg per meter square, but who had high waist circumference, that is more than 90 centimeters. Moreover, in this group, the amounts of both total fat mass and percent body fat assessed via bioelectrical impedance were similar to the group with a BMI of more than 25 kg per meter square and waist circumference less than 90 centimeters. Therefore, increasingly a combination of both weight circumference and BMI are being used to predict the risk of cardiovascular disease. In the future, simple clinically applicable tools to monitor changes over time abdominal visceral fat and ectopic fat need to be developed for use of BMI and waist circumference. Currently, the laboratory methods available are used mainly in the research settings. Coming to the gestational weight changes, the US National Research Council 2009 have compiled new guidelines for the gestational weight gain in response to the increase in proportion to US women for reproductive age who are overweight and obese. So, gestational weight gain includes gain in maternal and fetal fat mass, fat free mass as well as placenta and amniotic fluid. So, how these different components of gestational weight gain influence both maternal and offspring health remains uncertain. So, for the first time, the new US guidelines consider those health outcomes of both mother and child during and after delivery, which are plausibly related to gestational weight gain and the trade-offs between them. For the mother, the most important health outcome considered were postpartum weight retention and unscheduled caesarean delivery, whereas for infants the outcome were preterm birth, extremes of birth weight expressed as small or large for gestational age and childhood obesity. So, the new recommendations for the total weight gain during pregnancy and the pre-pregnancy BMI. So, calculations assume a 0.5 to 2 kg weight gain in the first trimester. Pre-pregnancy BMI was less than 18.5 kg per meter square. The total weight gain should be 12.5 to 18 kg to her normal weight. Normal weight pregnant women whose BMI laid between 18.5 to 24.9 kg meter square can gain 11.5 to 16 kg during her pregnancy, and overweight individual with 25 to 29.9 kg per meter BMI should gain 7 to 11.5 kg, and obese above 30 kg meter square can have a gain of 5 to 9 kg in her whole pregnancy. So, these new recommendations for total weight gain ranges for US women according to pre-pregnancy BMI based on the BMI categories of WHO. The rates of weight gain for the second and third trimesters are also stated. These recommendations have been adopted by WHO for low income population until specific country cutoffs are available. The growth indices, indicators and recommended growth reference data. The correct interpretation of grouping of the anthropometric measurements require the use of anthropometric indices. They are usually calculated from 2 or more raw anthropometric measurements. In the simplest case, the indices and numerical ratios such as weight by height square in kg per meter square and combinations such as weight for age, length or height for age, which is called as stature for age, and weight for stature are more complex. These latter growth indices are not ratios, and to avoid confusion with numerical ratios, they should not be written as weight for age, height for age and weight for height. Anthropometric indices are often evaluated by comparison with distribution of appropriate reference data for standard deviation scores, and from this the number and proportion of individuals as percentage with anthropometric indices below or above predetermined reference limit or cutoff are often calculated. The commonly used statistically defined reference limit for 3 main growth indices as Z score of -2, that is -2 SD below the WHO growth reference median. While used in this way, the index and its associated reference limit becomes an indicator. So, growth indicators are often used for public health or socio-medial decision making of the population. They are also used in clinical settings to identify individuals at risk for malnutrition. Examples of frequency used anthropometric growth indicators and their corresponding applications are the proportion of children of different age and sex with WH-Z score less than 3 is prevalence of severe wasting, and if it is less than -2, there is prevalence of wasting, and the proportion of children with +2 is prevalence of overweight, and if it is -2, prevalence of stunting, and if it is WAZ, that is weight AZ for age Z score, -2 is prevalence of underweight, and BMI if it is +1 and +2, prevalence of at risk overweight, and BMI of +3, prevalence of obesity. So, the WHO recommends the use of WHO child growth standards for young children from birth to 5 years for international use. These are called as growth standards, given small effect of ethnic and genetic differences of growth of infants and young children compared with the environment, nutritional and socio-economic effects, some of which may persist across generations. These new growth standards were developed because of technical and biological limitations identified with the earlier NCHS WHO growth reference. For boys and girls, charts from 0 to 6 months, 0 to 2 years, 6 months to 2 years and 0 to 5 years, for head circumference for age, length for height and weight for age, weight for length, weight for height and body index for age are available, and they are expressed as percentiles or Z scores. So, these data tables of Z scores and percentiles can also be downloaded from the WHO growth standards. The WHO growth reference for school age children and adolescents between 5 to 19 years or 61 to 228 months is recommended for international use. This is based on reconstruction of the original US National Center for Health Statistics data, which is supplemented with the data for under 5s from WHO child growth standard. The statistical methodology used for construction of reference was the same of that used by WHO child growth standards. So, for boys and girls charts for height for age between 5 to 19 years, BMI also between 5 to 19 years and weight for age between 5 to 10 years are available, expressed as Z scores or percentiles. So, all these growth reference data are available and they can be downloaded and compared. Concern over the impact of using the growth charts based on the new WHO child growth standard compared to the earlier NCHS WHO international growth charts on the estimates of malnutrition for children from birth to 5 years prompted investigations by several researchers. Such information is important because the result pattern of child growth following the intervention designed to improve the child health depends upon the growth charts that are used. Based on the growth indices outlined, compare the rates of underweight, stunting, wasting, severe wasting and overweight generated from the two sets of growth charts using two cross sectional data sets for children between 0 to 5 years, representative of different nutritional status profiles from Bangladesh and Dominican Republic. And important differences were revealed between WHO standards and NCH references that varied by age group, growth indicator and nutritional status of the populations examined. These same differences of age related patterns of stunting and wasting have also been reported between two growth references data when compared to the nationally representative data from India, and in general the populations with weight for stature and the rates will be greatest for all the ages, with the difference being especially strikingly during early infancy, and a similar pattern exists for severe wasting and applied for as a criteria for enrolling children in therapeutic feeding programs. So, this becomes a very important measurement for either planning or implementing the therapeutic feeding programs. So, we have certain global nutrition targets for 2030, where stunting target is to reduce the stunting by 50% in the number of children under 5 who are stunted. Anemia target is 50% reduction in anemia in women of reproductive age. Then low birth weight, the target is 30% reduction in low birth weight. Childhood overweight, the target is to reduce and maintain childhood overweight to less than 3%, and breastfeeding target is to increase the rate of breastfeeding in the first 6 months up to at least 70%, and wasting target is to reduce and maintain childhood wasting to less than 3%. Now, the elbow breadth is another great measurement for skeletal dimensions and hence the frame size. The measure is less affected by adiposity than many other anthropometric dimensions and is highly associated with lean body mass and muscle size. Elbow breadth is measured as a distance between the epicondyles of the humerus. For the measurement, the right arm is raised to the horizontal and the elbow is flexed to 90 degrees with the back of the hand facing the measurer. The measurer can stand in the front of the subject and locates the lateral and medial epicondyles of the humerus. The two blades of the flat bladed sliding caliper are applied to the epicondyles with the blades pointing upwards and to bisect the right angle formed at the elbow. So, care must be taken to ensure that the calipers is held at a slight angle to the epicondyle and that firm pressure is exerted to minimize the influence of soft tissue on the measurement. The latter is taken to the nearest millimeter and elbow breadth is used to calculate the frame index, and frame index is equal to elbow breadth into 100 divided by height in centimeters. So, this index is used as a measurement of external skeletal robustness in current and past populations. The studies have confirmed that a decline in the frame index in recent decades among young children in Germany, Russia and Argentina, a trend that appears to be parallel in increase in overweight and obesity. This decline in frame index has been associated with reduction in physical activity and also known to decrease the external skeletal robustness. In 2018, the reference percentiles for frame index were published for European children and adolescents. Then weight changes. The body weight is the sum of the protein, fat, water and bone mass in the body. Changes in the body weight do not provide any information on the relative changes among these components. So, increasingly the changes in these components of the body composition are assessed using laboratory based methods like the dual energy X-ray, absorptiometry and deuterium dilution and bioelectrical impedance analysis. And in normal adults, there is a tendency for increased fat deposition with age concomitant with the reduction in the muscle protein. Such changes are not evident in the body weight measurements, but can be seen by determining either body fat or fat free mass. In healthy persons, the daily variations in body weight are generally small, that is less than 0.5 kg. So, in conditions of acute and chronic illness, however, negative energy nitrogen balance may occur as the body can use endogenous sources of energy including protein as a fuel for metabolic reactions. Consequently, the body weight declines. So, in these conditions the total starvation and maximal weight loss is approximately 30% of initial body weight, at which point death occurs. So, in chronic semi starvation, the body weight may decrease to approximately 50 to 60% of ideal body weight, and in contrast with persistent positive energy balance occurs, there is an accumulation of adipose tissue and the body weight increases. So, body weight can only be used to assess severity of undernutrition in subjects with relatively unaccomplished and non-edematous and semi-starvation. In diseased condition in which edema, ascites is the fluid accumulation in the abdominal cavity, and dehydration conditions in which edema and diuresis, massive tumor growth and organomegaly occurs, or in obese person undergoing rapid weight loss. Body weight is a poor measure of body energy nitrogen reserves. In such conditions, a relative increase in the total body water, for example, may mask actual weight, and loss of that results from losses of fat and skeletal muscle. Massive tumor growth may also mask losses of fat and muscle tissue, which may occur during severe undernutrition. Hence, additional anthropometric measurements like mid upper arm circumference, triceps skin fold thickness should be taken to obtain more information on the origin of any change in the body weight. So, to assess the body weight changes, the actual and usual weight of an individual must be known. From these two measurements, the percentage of usual weight, percentage of weight loss or weight gain, and the rate of change can be calculated using equations shown in. The individual's actual weight can also be compared with appropriate age and sex specific reference data. So, here in this lesson we have learnt that the reference data is so important, so that we can compare the actual readings of the subject and come to a conclusion about their health status and nutritional status. Thank you.